One thing I definitely remember learning in like undergrad and graduate school was the fat cells before and after puberty. If a child they're not overweight before their puberty, after puberty, if they were to gain weight all of a sudden, they eventually, if they gain it, they can easily lose it, cut it like no problem, compared to a child who was obese before puberty. And then after puberty, they decide to lose weight, it's going to be more of a struggle for them to lose it. They're going to gain it back because the body's already adjusted to that weight, to that fat. So the fat cells, it's not about the fat they have, but it's the fat cells, the size. It's a lot more sensitive.
Yeah.
So that in a way is kind of works against the child if the child was obese or not before puberty.
You're listening to Musings with Morales, brought to you by Dialysis Education Services.
Thanks, Jonathan, for joining me again. Really want to take a deeper dive into a few things. We talked about health and wellness and fitness, and even a little bit about career and the journeys that we've been on in our previous discussion. But I really want to hone in on kind of where you're at now as a renal dietitian, interweave that with where I'm at as a interdisciplinary educator, primarily focused on training dialysis technicians and registered nurses, but also educating the renal community as a whole on things like best practices, device, things like that. You, on the other hand, kind of fill in those gaps in educating people on what they need to be doing between treatments. So let's start with the big problem. We've got high incidence prevalence of chronic illness in the United States. We'll kind of focus on a few of them: obesity, hypertension or high blood pressure, type 2 diabetes. The numbers are astonishing. All of these three things leading to chronic kidney disease, which we're both really focused on right now.
Yeah.
So can you tell me a little bit about your experience with those three chronic illnesses in the upstream side of things, of preventing, bringing awareness to those conditions, and really guiding people on how to delay the progression of?
Okay. Yeah. Well, again, Michael, thanks for having me. It's nice to be back. Yeah, definitely. This is an issue with the chronic conditions, chronic diseases. So you mentioned hypertension, diabetes, obesity, and there's a few other ones that do contribute to the progression of kidney damage, right? So there's like the 5 stages of kidney damage from 1 through 5. One of them being 3A, they divide it. And that's just, they do that in a way where you can see the patient's kidney function over from 90% to less than 15. When it's less than 15, doctor says you got to go to dialysis.
Right.
So let's talk about obesity. Well, where I'm at right now in my career, I work with those who are already end-stage renal disease. So it's already too late to do anything but just maintain their health, make sure that they can live as long as they can. If they choose to, make better choices, which is difficult because some of these patients coming into this stage or this point of their life, if at least for where I work at, they don't know that they were going to end up there because they didn't want to see the doctor. Like, oh, I felt good. Why am I going to see the doctor if I feel great? Usually for kidney damage, you don't feel the damage until it gets to 20%. You start feeling this low back pain. Some say, oh, it's a kidney stone, which it can be. It can be a gallbladder stone or back pain. But if they look at the labs, it's actually kidney function. If they see it, that can be one of the factors. And that's a big sign, like, hey, your kidney's giving up. It's getting tired. It's done with all the abuse, and it's getting to that point where you got to go on dialysis. So obesity is one of those things that do contribute to it, but it's not the main one. It would be high blood pressure and type 2 diabetes. The funny thing is when people ask me, hey, you're a dietitian, help me lose weight, it'll be an injustice for me to try to help them lose weight because I focus on dialysis. I do help them lose weight, but that's a whole other diet. So when it comes to at least hypertension, I focus on the sodium intake. The National Heart Association, they have this limit of 2,500 milligrams, I believe, or 2,300 milligrams of sodium. What is that? Well, a quarter of a teaspoon of salt is about 800 milligrams. So
Never already.
I have to check it out. Yeah. I think it's a little more. I think it's actually 1,200. Don't quote me. I got to check. But it's definitely high. So 2,300, that's really restrictive. For example, oh, here we go. A 1 foot long Subway. If you just get like the ham with the cheese and some other ingredients in there that are soaked in salt, like the pepperoncinis, the pickles, that stuff that make it taste really good.
Yep.
Right there, that sandwich, I've done this example many times. It's about 1,800 to 2,000 milligrams to that one sandwich.
So you're almost taking up your whole ration for the day.
For the
just
day.
with that. You know, it's funny. I always talk about Subway. It's like, what was it? Back in the day, Jared, right? Eat fresh, and it's like how to lose weight and all this kind of stuff, right? And we know for a dialysis patient, especially, when you look at that sodium on the cold cuts, like Subway Eat Fresh is not really that great of an option for them, right?
Yeah, the diet is definitely upside down.
Yeah.
They got to eat more protein. So for those who are with kidney damage between stages 1 through 5, their diet's a little bit different. They got to cut back on the protein, definitely cut back on the salt. But on dialysis, they got to have more protein.
Right.
So, Subway's just no good in general.
So Jonathan, you know, talking about those 3 chronic conditions, something that popped in my head, and these are numbers that change rapidly, so I don't want to get stuck on the number. But when we look at like where we're sitting, you and I, in a dialysis clinic, the nephrology world at end stage, really, CKD 5, right?
Yeah.
We see a lot of type 2 diabetic patients. We see a lot of hypertensive patients, and then we've got a slew of different etiologies for their kidney failure, right?
Right.
But there are right now an estimated 1 in 7 Americans that have chronic kidney disease. That's not representative of the people that are sitting in dialysis centers, but it's the people, like you said, 1 through 5. There's 1 in 7 Americans that are suffering from that, right? So that's like what, 37, 40 million people that have chronic kidney disease, right? And then when we look at the numbers with type 2 diabetes diagnosed, we're like 37, like in the same range, right? And then we look at the hypertensive population in the United States, diagnosed, right?
Right.
And also the pre-diabetic population, they're over 100 million on each. So a third of the country has one of these comorbidities. There are certain things that are not in our hands that are, you know, I'll say fate or genetics, or, you know, nothing I do could stop it, right? Mm-hmm. And then there are others that are, for the large part, preventable. Would you say that hypertension, type 2 diabetes, and obesity, in your experience, are preventable? And are they reversible?
Good question. So of those 3, genetics do play some part, but it's definitely a diet driven. A lot of it's caused by the habits, whether it's the poor choice of foods, whether it's because of your environment. You know, you grew up in a neighborhood where, hey, just the Carl's Jr. down the street, McDonald's down the street, grocery store is 3 miles away. I don't have a car. Why walk over there when Carl's Jr. is right around the corner, liquor store's right around the corner, get myself a bag of chips, hot dog, there's your breakfast, lunch, or dinner, right? Poor choices, but it's because of, again, your environment. But yeah, those 3 are usually caused by habits, bad choices, poor choices, sometimes whether it's education or it's financial or just, to be just straightforward, just poor choices. Right. And not really aware of the long-term effects of it. So for those 3, obesity definitely can be reversed, but that's depending on how long the person's been obese and when obesity happened. So one thing I definitely remember learning in like undergrad and graduate school was the fat cells before and after puberty. So if a person is a child, is they're not overweight before their puberty, after puberty, if they were to gain weight all of a sudden, they eventually, if they gain it, they can easily lose it, cut it like no problem. Compared to a child who was obese before puberty, and then after puberty, you know, they decide to lose weight, it's going to be more of a struggle for them to lose it. They're going to gain it back because the body's already adjusted to that weight, to that fat. So the fat cells, it's not about the fat they have, but it's the fat cells, the size. It's a lot more sensitive. Yeah. So that, in a way, it's kind of works against the child if the child was obese or not before puberty. Yeah. So that's a crazy fact I learned, and it just blew my mind. I was like, whoa, okay. So that is definitely something we can't control. But as a parent, if you were aware of that, you would probably have your child more involved with physical activities. Don't put them on a crazy diet. They're children. They got to eat. Just give them better choices. That's what I'm saying. Don't starve them to death. That's also unhealthy.
Right.
And that's a whole nother field of psychology with feeding children and parenting.
I was, I don't know, 10 years ago, I was admitted to the hospital. I can't really remember what it was, but it was serious. So I kind of skipped the waiting line in the ER and went straight in. And there was a little boy in the lobby. I remember this. They had been sitting there. You could tell he'd been sitting there for a while.
Okay.
With his mom, and he's probably like 4x4, right? Like he was as tall as he was wide. His mom was the same way. And I got in and I got stabilized or whatever. And then the kid got in and I could hear him next to me, and the physician talking to the mom, and he had like, he had some sort of abdominal pain. What has he been eating? Oh, he had a 20, I remember it's so funny, 20 pack of chicken McNuggets, right? And an ice cream and, a large fries and a supersized soda. That's what the mom told him. And I'd never heard a physician rip into a person as much as I heard this physician rip into the mother. And make it very clear that you fed it to him, that he's type 2 diabetic and you're putting this into his mouth. Experiences with this, you mentioned childhood. Typically in dialysis, we're seeing people in the aftermath of years, decades of that sort of activity. But any experience with that in your own professional or personal?
Yeah, I mean, it gets to the point where like food, as I mentioned in actually with a few patients and teammates and family members, that food is the food that we eat in our culture is tied to our identity. So if you think of tortillas, what do you think of? Mexican, rice, Asian, or Mexican as well, because like we freaking love rice, right?
Yeah.
So it's hard to tell someone if they've already associated themselves with this food, this is my identity, to remove it. It's difficult, not impossible, but definitely difficult to do. Yeah. So when it comes to like for myself growing up, it was mostly Maruchan because my parents were out busy working. Maruchan was there, cup of noodle, hot water, boom. It was delicious, smelled great, not knowing it was high sodium. But I was a kid. I mean, my parents didn't know any better, right? Their highest education was high school, and then maybe a little bit of college, but didn't finish. So what would they know about nutrition?
Right.
I don't blame them. Now hindsight, I started learning all these things like, oh, wow. Again, it comes back down to what are the schools teaching the children, and also how is this information available to parents, especially nowadays who are busy, depending where you live, California, expensive.
Yep.
People work 2 jobs. How are they going to have time to study these things and still tend to their children?
Right.
Right. So for me, I had pre-diabetes as a little kid because I love drinking my tea with a lot of sugar. Like, oh, it's healthy. It's it's not soda, it's not juice, it's sugar and tea. But it was the sugar that did it.
Yeah.
That was middle school. That was a turning point. And then the doctor said, hey, you know what? Pre-diabetes. I stopped eating all the sugar, all the candy, and it went away. Of course, my parents got me involved with soccer.
So you're active and switched up on the diet a bit.
Yeah. But I was fortunate. Not many children have the full support of their parents. My mom, she was a manager for apartments. So when I was home from school, she was there anyway. Whether she was cleaning a unit in the same building, she was always around.
Yeah.
And parents being around the children are more likely to succeed, whether it's health, financial, and so forth. There's like crazy statistics on that as well.
So that's the second time you've kind of brought up the history with pre-diabetes since we've started talking here. And I got into dialysis for like very personal reason. Not that I'm on dialysis, knock on wood, I never will be. But it was kind of had to, as far as working with a family member who was on dialysis, learning how to help them with the process. I really fought the opportunity to care for other people for quite a long time. I didn't do it right away, although I could have done it straight out of high school as a dialysis technician, right? But eventually it made a lot of sense that like I grew up with somebody who went through this plight. I grew up I would say, blue collar, with struggles in life. And I could empathize with people pretty well because of the plights that I've seen from multiple angles, right? So as a dialysis technician, it's kind of makes sense, right? Like, hey, he grew up here. This is what he's going to do. Like, it makes sense.
Yeah.
What's that journey like for, a dietitian? We can start with you, but if you had to say, like, this is who a dietitian is, and especially a renal dietitian, like, how do you get there? Like, why?
Why? Well, right now, it's still to today, for any dietitian to become renal dietitian, to be specific, to be expert in that, they need about a year's worth of clinical experience. So whether it's outpatient clinic or in the hospital. For me, it started with working with the diabetes population back in Texas. I was there for about 2.5 years with that company. Nonprofit, loved it. I loved it. That's when, and also I was also focusing on the kidney health and chronic kidney disease for my master's project.
Okay.
During master's school or graduate school, excuse me. And I said, okay, well, I was teaching diabetes and I kept hearing loss of kidney damage. And I would work in 2 separate clinics. I eventually gained the doctor's trust. I don't know if it was too hard or if it was because I was very perseverant. I was very motivated because I would have the computer in front of me. If my 1 o'clock or 2 o'clock appointment didn't show up, like my 1 hour session with the patient that was going to help control their blood sugar or prevent it or high blood pressure, I took the initiative to go look at patients who were visiting the clinic at the doctor's within the 15-minute time frame. Okay, I'm going to look at this patient, but let me look at their labs. I see, diabetes or no diabetes, and then I look at their kidney function because I was already curious about it. And I would see, they have 40%. That's what I'm going to talk to them about. So I would go to that whatever part of the clinic they were going to be visiting. I would talk to the technician, the LVNs, the doctors. Say, hey, can I talk to this patient before you do? Yeah, go for it. What are you going to talk about? Kidney. Good. And I asked the patient, and it happened almost all the time. When you said one out of like 7 Americans are diagnosed CKD, I think 2 or 3 actually know they even have it.
Well, I was going to go there. It's like, what? So you run into these people. How many of them actually know they're in kidney failure? Or I should say that they have kidney disease, whether it's 3, 4, 2, how many of them, like, what's your experience on that side? Is most of them are coming in blind to that, or they know that there's an issue here and, that it's progressing and kind of end stage is imminent if there's not changes, right?
Yeah, the funny thing is that I can remember no one knew. Every single one that I spoke to, and one did, it's because I forgot I spoke to that person because I was just so just aggressive about it. I'm going to go see this person, and there was one person that I forgot I spoke to a few months ago that they were visiting, and they said, I remember you. I said, oh, that's right. I forgot your name, but I remember what he looked like. And their kidney health got a little bit better because they were asking the doctor to check my kidneys again, but I'm gonna make some changes. It was blood pressure. But yeah, it was, from what I can remember, nobody knew that they were at whatever stage, whether they were at 40%, 30, 60. And some of them I did bring to tears. Not intentionally, but it's because they weren't aware. And that just spooked them. Yeah. And it's not about scaring. It's about just bringing realization. Like, this is reality. Yeah. This is, you can live the rest of your life with 60, 50, 40% and avoid dialysis. Right. Let's prolong. Or if you get to that point, prolong it. Get there when you're 80, not when you're 70 years old. Yeah. Or if you even choose to want to live that long after 80 or 90, right? Depending on person's priority in their life and everything. So yeah. A lot of them didn't even know.
Yep.
Yeah.
So in my graduate studies, I really went through disparities, racial disparity studies specifically, and looked at the way that cultures view healthcare. And one thing that Latinos tend to be stereotypical norm is that they wait until it hurts or until they're sick, or they really don't feel like they can carry on through the day before they go to the doctor, right? And we've heard this term like silent killer for type 2 diabetes and hypertension, right? So you've got type 2 diabetes, you got hypertension, it's silent until you feel it, then you end up going to the doctor, and the doctor says, hey, yeah, you're a type 2 diabetic, right? And by the way, your creatinine, your GFR test, whatever, we need you to go see a nephrologist. And it's like, Friday I found out I'm type 2 diabetic and I got to do all this stuff, right? And then Monday I end up at the nephrologist, or Tuesday I end up at the nephrologist, and they tell me you have CKD5 and you're going to need dialysis on Wednesday or Thursday, right? Like, experiences with this as well. Is this pretty common? And you know, what's the dialogue on that from you, as far as like the cultural machismo within the, you know, I say especially with Hispanic males, right?
Yeah.
Not wanting to go to the doctor, not to see the physician till, like I said, it hurts.
Yeah. I mean, my father's always been like that. It's like, I like to see it. I mean, push came to shove. My mom and I finally convinced him up a few years ago, and the numbers came back fine. He's like, see, told you. I'm like, okay, great. Keep proving us wrong, but get checked every year.
Yeah.
You know, with age, things start to work at 80, 70, 60%. And with age, things get older. We don't get younger, right? So after the age of 40, we start losing kidney function.
Right.
It doesn't mean we'll end up on dialysis. That's just a sign of aging.
Yeah.
So with those patients we call them crashers. That's what happens. They
Crashing
crash
into
in the
dialysis.
hospital and into dialysis.
Yeah.
And it happens way too many times. So when I asked them what was the cause of it, they're like, I don't know. The doctor told me I had to come here. I'm here. It's been a month. I don't know why. I'm like, okay, well, I let them vent first. Like, and I give them all the time they need to vent. I get it. Because even if this is what happens. Sometimes they do get their annual checks, whether they're Latino men or women or any kind of race, right? If the patient goes, like I've seen this by my mom firsthand. She goes in for a headache. The doctor resolves the headache problem or back pain. They do all the lab works, but they're not going to spend 15, 20, 30 minutes reading the lab works. You're like, here's a paper, let me explain to you what they mean.
Yeah.
They don't do that. They will address what's wrong with you and out. It's
Right.
your number.
Right.
Next person.
Yeah.
Next person.
There's a lot of other things that should have been touched on, is what we're saying, huh?
Yeah, and we're not taught how to read on this stuff in school. Not just Google.
Yeah.
But again, it takes that extra effort to, what does this value mean? It says hi. What does it mean? Let me Google it. So that's the issue. There have some patients that have had long follow-ups with doctors, and you see the trend going down. But if they said they didn't know, they probably didn't know. No one mentioned to them, hey, you're losing kidney function. And then all of a sudden you're here. So I let them vent, and they say it's the doctor's fault. In a way, it is, because they didn't raise the red flag. Hey, let's avoid this. Nothing preventative, right? But it's also, again, we have to be held accountable for checking all those things too.
Yeah.
But yeah, it happens a lot. I let them vent. Like, if the doctor's fault, let's blame the doctor. Okay, now what do you want to do? Now we're at this point. Do you want to continue, with the same habits, or do you want to change? You want to feel better? And a lot of them feel better after the first month of treatment. And some don't. Again, whether it's resentment or it's just the pain, or just still, what is this word I'm looking for? In denial, Yeah. So, but for those who are not on dialysis, I always suggest getting checked every year.
Right.
You don't wait for pain, right?
Yep. Annual visit, kidney screening as a conscious choice or a conscious conversation.
Yeah.
In those annual visits, right? So Jonathan, just, when we talk about those chronic kidney disease numbers, those type 2 diabetes numbers, those hypertension numbers, the data shows that there are higher incidence demographics as well as races, right? So we know that African American, Hispanic, Latinos are of the highest incidence of all of those things. Can you talk a little bit about your perception of why those demographic or those races are at the top of the list as far as risk factor?
Right. Yeah. It comes down to just like the cultural habits of the food. So here's something very, very interesting. I learned epidemiology, the study of diseases, back in undergrad. People or immigrants that came from their country that with no health issues come to the United States, all of a sudden become obese, have high blood pressure, are at risk of having diabetes or get diabetes. So was it the Mexican food that was it, or was it the food in the United States, the integration of American with Mexican food? You know, is it is it again the environment settings? Because when we go on vacation, we do a lot of walking. We don't really drive.
Right.
You know, we go to the country like, oh, this feels great. Why do I feel energetic? Because you're walking. Yep. Right. You're back in your hometown, your home country, your own city. You're driving everywhere. Like, why do I need to go to the beach?
I'm big on like when I go to a business, Jonathan. Like I'll look at like, hey, disability access, stuff like this, right? And we just went to Cancun recently, and it was an all-inclusive resort. And I was like, hey, these stairs are really steep, and there's a lot of stairs. How are people who are disabled going to get around? My daughter said exactly what you just said. She said, like, well, you know, people in other countries are healthier than in the United States. Maybe this is part of the reason, right? And I was like, oh, yeah, that makes a lot of sense. Like, there's no consideration for making it easy in a lot of places, right? It's going to be hard to get to the place to have the nice dinner or the nice lunch or something like that.
Yeah. And in some other countries, they live a really rough life. Like, we're pretty privileged out here in the States, you know?
So there's a consequence maybe to some of the privilege that we have, right?
Yeah, it really is. Like, these things are a little bit easier for us, for a lot of us here.
Yep.
But yeah, for the Hispanic, the tortillas, at least in Mexico, they're made fresh by hand.
Yeah.
When I went to Peru 2 years ago, there's restaurants everywhere, but everything's made fresh.
Right.
You know, nothing is, you get this batch of frozen chicken and you just deep fry it or you reheat it. No, everything is fresh.
Yeah.
So, again, that has to do with the quality of the food. Here, you know, if you can't go you don't want to cook anything, just go to the fast food restaurant. Right. Again, that affects everything.
Yep.
But it's all high salt. So, and then it relates to the African American community. Again, soul food, if they like their deep fried chicken, that's an issue, right? The fat and the salt, it's a cultural thing.
So to my understanding, specifically with the African American population, that there are unknown like anomalies in regard to hypertension, that it may not be environmental, it may be genetic. So what are your thoughts on that, or your experiences, your education, your background on the specifics of the African American incidence of hypertension or chronic kidney disease?
So it's not much I remember from when I did epidemiology, but a lot of it has to do with just the salt use in the food. Honestly, it's just the use of salt and just the stuff. It's more of an American thing. Average American use 5,000. We consume 5,000 milligrams of sodium a day.
So that's 5 grams of sodium a day.
5 grams.
Yeah, which is more than double what the maximum recommendation is by the American Heart Association.
Yeah. So then when it comes to cutting back on the salt, when we get to that point where we're forced to cut back because our blood pressure is high, everything tastes bland. But it's because we got accustomed to eating 5,000, 6,000 milligrams of sodium a day. So the same thing happens with not only the Afro-American community, but also the Latino community.
My wife's Filipino, so I know a lot about salt. I mean, a lot about salt.
Fish sauce.
Oh, fish sauce.
So I always tell this story. The first time my wife cooked for me, we were dating, right? She's like, I'm going to come to your house. I'm going to cook for you. And she's like, okay, give me a pot and some chicken and some soy sauce and something else. I forgot what. But I had a brand new bottle of soy sauce, right? Ooh. Which I think I still would have today if I never met her. Seriously, like, the restaurant bottle, right? I probably would have never used that whole thing, but she took it and she took off the cap and she dumped the whole thing in a pot with the chicken.
Yeah.
And she's like, do you have more? I was like, what the hell? I literally had to get more. Now we have like gallons at that, a lot of salt in the food. But it tastes good.
It does. Yeah. No, I bet it does.
It tastes good. So again, Jonathan, there's a lot to be said about the chronic illnesses that lead to chronic kidney disease, and the preventable nature of those. A lot of education that needs to be done on the cultural, the community level, and then we could kind of debate on whether upstream dollars are more valuable than downstream dollars, or how to weigh that out, because we spend a lot of money right now in the United States on end-stage renal disease. We spend a lot on chronic kidney disease as well.
Yeah.
And I'm talking like in the cumulative between chronic kidney disease and end-stage renal disease, like in the $150 billion a year range. It's a lot of money, right? It's a hungry kid in the group of Medicare beneficiaries, right? It's a high cost complication, and it's an entitlement under for Medicare benefits, right?
Yeah, I gotta add something to that. That's right. When I did my focus on chronic kidney disease with my master's program, and I saw the average spent on a dialysis patient back in 2017, 2016, it was the insurance had to pay $90,000 minimum for one patient a year.
Right.
Now it's probably more with inflation.
Yep.
And a few months ago, a patient, he's still bitter about the whole healthcare system and dialysis. Like, this is a business. You only have me here because you're getting money out of my insurance. Like, okay, well, I let him vent and say, you know what? It's true. Dialysis is a business.
Right.
It is. I'm not gonna lie to you. It is a business to keep these people alive. If you want to live a little bit longer, dialysis might be is your only treatment. You can stop and cut it, but if you go back to the hospital because your kidneys aren't working, you end up here.
Right.
You choose to be here. Now, it's to help you. Do you think these insurances want to cover you? Do you think they want to pay $100,000 for you to live a little bit longer? No, they probably don't.
Right.
But we have that privilege to do that, to live a lot longer. They'll cover you.
Yeah.
So I'm not gonna lie to you, that's not a business. It is a business, but it's to keep you alive a lot longer.
Have you seen the documentary called Who Shall Live?
No.
Okay, you got to watch it, and we'll post it on the comments. But
Okay.
I think it's like 1965, and if you don't know, or if for anybody who's watching doesn't know, that 1972 Congress passed a law, the ESRD Entitlement Act, right? So now people with kidney failure, CKD5, would actually qualify for Medicare or Medicaid services, right? Whether it's Medicare only or Medicare plus Medicaid, like Medi-Cal, or the equivalent in another state, or just Medi-Cal if they don't qualify for Medicare. They do have insurance coverage, right? So that started 1972, implemented 1973. Before that, people actually they would die of kidney disease, right? You had kidney failure, you're going to die. And the biggest hope was that you live near a research center where they had these dialysis machines that we all take for granted today, right?
Get out of here.
But they had these machines, and you had to have $10,000 per year, a 3-year deposit, and you had to go through several committees, which would basically qualify you for that seat. And again, so you had to be in the right place. You had to be assessed or evaluated. So let's say there's 5 of us that need dialysis and had the money to pay for it in this center. They go like, who shall live, right? They're going to evaluate us. It's a really tough documentary to watch, especially if you're in this industry, to kind of understand how we got to where we are today, where everybody's going to get treatment, where just not too long ago, right? In the early 70s or prior to the early 70s, people were just dying of this, drowning in their own fluids, dying of hyperkalemia, things like this, right? So we're in a really great spot when it comes to reimbursement today. But let's go down the road of, okay, I had type 2 diabetes. I crashed into end-stage renal disease or kidney disease. Now, like you said, the choice is a few things. It could be hemodialysis, it could be peritoneal dialysis, it could be a kidney transplant, or it could be conservative management. And I want to start with the last one with you to find out what sort of experiences or dialogue you would have on conservative management. I'm 85 years old, advanced Alzheimer's, chronic kidney disease, type 2 diabetes. And let's just say that, I've got 3 months with or without. 6 months with or without. And I decide that I don't want to do dialysis because that takes time, right? It takes transportation back and forth. And I want to spend my last 6 months comfort doing the things and seeing the things and being around the people that I want to be around. Any experience with palliative care or hospice?
I've heard not worked. I've had, I think, 2 or 3 patients. I can't think of the number off the top of my head that chose that route at the end. It's been a while. Before COVID, it was like maybe 2 or 3. After COVID, I haven't seen any. Um, and it is tough. Usually that conversation is held with the doctor. They didn't approach me what they should do diet wise. They were to ask me, I would just say enjoy it. Honestly, if you're choosing to enjoy the rest of your life without any type of dialysis treatment, okay, hands off. It's just your choice. There's no judgments. That's your life. No one should judge you for what you want to do with your own life, with your with your own body, and enjoy the food. Enjoy the food that was once taken and being restrictive. Go ahead and enjoy it. Have it with your family and friends.
Yeah.
So
I talking about like culture is part of the identity. It's part of culture, or sorry, food is part of your identity. It's also part of your culture. It's part of the way that some people express their love language, right? It's part of family connection, especially in certain cultures. Like you get together with your family, you eat. You don't have to smile at each other, but you have to eat, right? You eat, right? That kind of thing. Let's go on the inverse. If I am going to choose to take a therapy, and it's going to be something that's maybe transition towards transplant, so hemodialysis or peritoneal dialysis. You mentioned like these restrictions. What are the common restrictions for people with end-stage renal disease? And better yet, let's say, what are the common considerations? Because I think I know that somebody who has a GFR of 14 versus somebody who has no residual renal function at all, meaning zero kidney function at all, right? That they have a different prescription. What are the common considerations for these patients?
Oh yeah, no. Right now, there's a big push for home dialysis, especially peritoneal, because it's actually there's been statistics been showing that patients on peritoneal dialysis are less likely to end up in the hospital and less likely to die. Given to popular belief, it's funny, the patients in our clinic that hear from other PD patients that are temporarily not doing peritoneal because they got an infection in their catheter.
Yeah.
They're telling them, oh, don't do it. Like, you're going to get an infection. You're going to end up here. What's the point? The statistics, I think it was like less than 5% of the PD population get some type of infection in their IV. So the ones that end up in our clinic temporarily, they're the 5%. They're not the whole 95%.
Right.
So they're spreading this misconception like you're gonna get an infection. And then with further investigation, you start asking, well, did you use a glove during the prep? No. There's your infection. You got to wear a glove. Everything's got to be clean. Once you're connected, you can be gloves, hands free. Right. So again, it comes down to the education. But in terms of PD and home, I would definitely try to push for PD because it's freedom. I mean, they can dialyze while they're asleep or when they're working. They don't have to be stuck in a chair.
Do you work with PD patients, Jonathan?
I work with dietitians that work at PD. In my clinic, we're only in center. But when we do educate, they go to the other clinics to train while they're doing their dialysis with us. And once they're fully trained and they're confident in doing PD, peritoneal dialysis, they leave us.
Right.
And they love it. They absolutely love it.
So let's kind of paint the picture of, I have kidney failure, 368 hours. Is that right? 368 hours, I think, a week, right? No, 168 hours a week, sorry. 168 hours a week. I don't know where I'm getting that. 168 hours a week, my kidneys work, right? Now, if I have no function of my kidneys, I go to dialysis, let's say hemodialysis. That's where you work, right?
Yeah.
And I go Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday for 4 hours. And now, like if we said 168 hours of kidney function, and now I'm doing it all in how many hours in the dialysis center?
If it's 3 hours, it's 90. Doctors want 3.5. Patients like, I don't want to be here for 3.5, and they cut it to 3, maybe even
so less. Let's call it 3 to 4 hours each time. So
yeah.
We're calling 9 to 12 hours of kidney function now. You used to have 168, and now you have 9 to 12 hours of that same function coming through the dialysis machine, right?
Yeah.
And then if they were doing peritoneal dialysis, how often do they do that?
8 hours. I've heard 8 hours a day.
8 hours a day. So there's two types of peritoneal dialysis, right? There's the ambulatory where they do manual exchanges of this fluid. They fill their belly. They walk around for 3 hours or so. They drain it. They fill it back up and rock around for 3-4 hours, drain it, and they do this all day long, right? So that's ambulatory manual, and then they also have a cycling where they do that while they're asleep, right?
Mm-hmm. Yes.
So it's called continuous as well.
Continuous.
So it means that they're kind of doing it all the time.
Yeah.
What we know is that hemodialysis is much more efficient, like it gets more done in a shorter period of time. But peritoneal dialysis, because it happens all the time, there's less peak and valley to things like fluid, sodium, waste levels, right? So you mentioned you haven't worked with them, but you've worked with dietitians that are working with peritoneal. What's the report of like the feeling, the quality of life in regard to having more frequent or more continuous type of therapy versus an aggressive intermittent therapy?
The blood is cleaner. I mean, because they're constantly cleaning their blood daily. So their diet is not as restrictive as the home. I mean, as the in-center, what I do.
Yeah.
Because again, you're only dialyzing 3 days a week, so it's a lot more restrictive. The fluid's about the same. The restriction's about 1,000 milliliters or 32 ounces, which is 2 regular sized water bottles.
Okay.
I mean, I got my water bottle right here. This is 64 ounces. This is that's
Too much.
way too much. And yeah, so the diet isn't as restricted for peritoneal dialysis because they're constantly cleaning. The biggest issue for peritoneal dialysis patients is the low albumin, the low protein. That's what dietitians have to really strive for PD, try to get that number up. And that's
So what's the big deal with albumin?
It's just a constant exchange of fluids. The protein just drops. It just drops. So
But why? I guess my question is, like, why do we even care about albumin? Like, what? Because I know that's a really big deal for all of us, but specifically for people with chronic illness, specifically for the aging. I've worked in the nursing home post-acute care side of things, people with wounds. So what's the big deal about albumin? Why exactly is that a real focus, especially from your end? And I know the numbers are hard to keep for dialysis patients.
Pretty much, albumin, a protein, is found. It's in our hair, it's in our skin, it's in our immune system. It's a building block. DNA, right? So when it's low, there is definitely, I said 3.6 or lower, and the lower the albumin, because the goal is 4.0 or greater.
Right.
When it's 3.6 or lower, they're at higher risk of infection, hospitalization, and death or mortality.
Yeah.
So that's why it's a big push. And if it's low, they're also at high risk of swelling, edema, the buildup of fluids.
Yeah.
So
yeah,
it helps with wounds. So if it's low, it's a big problem. So the problem with albumin or protein is that it can be affected by different things. It doesn't have to be nutritional. If the patient's not eating right, that can drop it. But if they're eating chicken, beef, pork, tofu, eggs, and the albumin's still low, it's something else. It can be an infection, an inflammation, whether it's the gums.
I got to tell this story. Every time I think about albumin, I had a patient in, I don't know, 2003 or so. It's a pretty young patient. She held a job. It was, I think, 10 or 12 hours a day.
Yeah.
She worked every day. She was a longshoreman, right? And when she was at work, she wouldn't eat. She had diverticulitis. So, a chronic inflammatory condition of the intestines, right? Yeah. And if she would eat at work, she would, have bowel movements that would blow up the bathroom. She would have flatulence that would scare her coworkers and kind of stain her clothes with smell, right? So she'd come to dialysis at the last shift of the night, right? She was my last patient. She'd always bring a box of El Pollo Loco or flame broiler, just pure meat, right? Yeah. She could feed the whole clinic with what she brought, by the way.
Wow.
And be like, whoa, she's bringing a lot. Well, she had really low albumin levels, right?
Yeah.
Why? Because she wasn't eating during work, right? She also had diverticulitis, which messes with absorption and things like this, right?
Does. Yes.
So she'd bring that food in. We'd get her on. She'd start eating, and she would pretty quickly have to use the restroom, and it would interrupt her treatment. She'd have to go back and forth. Diverticulitis can produce some pretty foul smelling gas and bowel movements, something that we all as professionals can get used to and shouldn't ever express that we even catch a whiff of it, right? So one day we had a new student or a nurse in the clinic. There was a student.
Okay.
And she walked by this patient, which was between the bathroom and the hallway. And she smelt that she had just went to. She was like, "Oh, what? Whoa!" She made a big deal of like she smelled it, and it was really heartbreaking because that was a Friday. The next Monday, the patient caught wind of that. Right, she heard the nurse walk by and go like, "Oh," like she was grossed out. Right.
Yeah.
So Monday, that patient, I had been working with this patient for quite some time. I never saw her without El Pollo Loco or flame broiler. But Monday she came in with no food. And, I asked her, I said, "Here, where's the food?"
Yeah.
And she's like, "Well, if I don't eat, I won't do this." And the thing that it really touched me was that, like, as caregivers, sometimes our patients care about our comfort more than we care about theirs. And that's just not the way it should be, right? We corrected that really quickly and made sure that this lady she had low albumin. She needed to eat. This was her time to eat after a 10, 12-hour day, end of the day, right? She needed to eat. But yeah, it's super important. And I've worked in the nursing home settings where patients with wounds, if they're not getting good nutrition, those wounds are not healing.
Right.
And that's just, the whole picture of healthcare. Nutrition is such a big piece of it. So we talked about the in-center dialysis. We talked about the peritoneal dialysis. We kind of touched on home, with peritoneal being one of those modalities for home.
Right.
Then there's hemodialysis at home, which could be same efficiency as in the center, but at home. It offers, in some cases, less restriction, right? Depending on the frequency and the treatment time. Have you worked with many home hemodialysis patients?
No, in our region, we don't really have home hemodialysis patients. We had one patient that did go in that route, but that was a whole different region. He left, so I don't know what really happened. If you can tell me more about it, that'd be great. I don't work with any.
Well, I guess, what would you choose, Jonathan? Just knowing the landscape, if it were Jonathan Diaz and you found yourself in the position of your patients, what would you choose? Be in the center, do home hemodialysis, do peritoneal dialysis, and I'll throw out there as well. Would you feel comfortable in asking the people that you love or that love you if they would go get checked out to see if they're a match for a living donation?
Yeah, that's tough. I would definitely do PD because I love to work.
Me too.
After
for that same reason.
Yeah, it's like if you go to in-center, okay, you 3 hours, the rest of the day you're off, and the next day. But a lot of patients feel very weather tired because 3 hours of intense blood cleaning is draining.
Yep.
To be honest. So yeah, PD. With more freedom, you can do a lot. And I don't know if I would ask for a transplant so soon, knowing that it takes about 10 years to wait. I'll probably have to build up some courage to ask my family, just because you have to ask myself, was it my fault they got to this point, or was it genetics, you know? And then if it's genetics, then we have patients that are in their 30s and it's lupus they got them there. So the nice thing about those with lupus is once they do get on the transplant list and they do get transplanted, the medications actually are beneficial for those who do have lupus, because it stops the body from attacking
the immune
itself.
system.
So if that was my case, then I would ask, like, you know what, I know I have is genetic. It's something that was out of my control.
Right.
But if I do get a kidney transplant, here's the process.
That's interesting. So you feel a certain level of you would feel a certain level of accountability towards your plight, and whether you're asking for a bailout, for lack of better words.
Yeah, because I know what the first thing that doesn't come out of my family member's mouth is, how are you gonna take care of my kidney?
Yep.
Yep. Are you gonna kill this one like you did this one? Like, and then you start.
Yep.
Yeah. So that's a tough topic. It's a tough topic, and we've had some patients that actually family members, without even getting asked, immediately, I'm gonna donate my kidney to my father or my mother.
Yeah.
And
I've actually had many people in my business, like training techs and nurses. They started because their family member had it. I've had many young people that wanted to give their kidneys to their parents, and were basically steered away from that from the transplant teams, which is, I think a controversial area of medicine today, living donation. We've always we've heard for years, like the donate life, and that, you know, we can function perfectly fine with one kidney. Then we've also seen people who have donated their kidneys fall into kidney failure and get moved up on the list as well, right? So, you know, something I think to really, I would never want to be in that position, but I think I'd be in the same place as you. It's like, you know, would I really ask somebody that I love for, and no, not knocking anybody who's received a kidney transplant from some, but for me personally, it would be a really difficult conversation and a difficult decision to come by on whether I would even feel comfortable in asking that. So Jonathan, I train a lot of techs over the years. I probably trained, I don't know, in the thousands of technicians. And one thing that has really, I think, improved over the years is the perception of the technician in the interdisciplinary team. It's kind of fluxed over the years. There were times where the techs were part of like the IDT rounding. I see clinics that they're still doing that interdisciplinary team rounding, right?
Yeah.
So you're a dietitian, you're out there seeing patients, you know, we draw at least monthly blood work on them. You come in and talk to them on the response of those or the results of those blood works and tell them, good job, bad job, change this, keep doing this, these sort of things, right? Recipes, which I was really impressed with some of the recipes that you have, and just the way that you make it more approachable. But if you could give any advice to people who are technicians that are really kind of like, when you look at a nursing home, the CNA is the most contact with a patient in a nursing home, right? In a dialysis center, a dialysis technician is the most contact with the patient. You see them for a certain number of minutes every month, right? The dialysis technician sees them for the 3.5 hours every single treatment plus some time, right?
Yeah.
And I can tell you many times they've asked me, like, when the dietitian walked by, they kind of pretended like they're asleep. They get a paper put down on their desk, and then they go like, "Hey, Morales, you know, what does all this stuff mean, right? What do you think about this?" And I'm like, well, you know, Jonathan has a degree in this stuff, right? That's what he does.
Yeah.
He's the expert in that. So if it's coming from you for a dialysis technician, what's my job in relation to supporting the patient's nutritional goals, the what do you call it, the encouragements and the restrictions, and how do I work with you as a dietitian?
Yeah, it does come down to the dietitian. Honestly, the certified dialysis technicians, they are vital. They are so vital because they're the ones that build the rapport with the patients. The patients trust them more than me or a social worker because in the end, the technicians are the ones sticking them with 2 big needles.
Right.
Hell yeah, they're gonna trust them.
Right.
You know?
Yeah.
So yeah, it's that rapport is huge. That connection and trust is huge. So, you know, not so much with the dietitian. Social worker, maybe something there because, you know, there are some things that report to them that's very confidential.
Yeah.
But then it comes down to myself or the dietitians. Do they make the effort to sit there, get to know the patient, talk to them, educate them, and not judge them? I know there's some dietitians that judge. You don't do this, you die. And then that's it. And they move on to the next patient. Like, how is that going to help?
Yeah.
If they don't know what to do, and again, there's some patients that don't want to make an effort. That's okay. Just don't judge them. That's their choice.
Yeah.
You just move on. You just help the ones that want to be helped. Or, you know, they're crying for help, but they don't know how to ask for it, right? Whether it's a sense of like their ego. You know, mostly it's the women that are very good at coming up with asking for help. They're very great. Some of the men are not. So, and they're like, oh, well, if I die, I die.
Tell me more about that. Like,
Yeah.
what's your thoughts on that? Like, why are, in your experience, I mean, maybe it's you're a young, good-looking guy. Maybe that's why they're opening. I don't know. What is it that makes women open up and share their needs, in your experience, more than the male patients? And what region do you work in California, by the way?
Okay, so I work in the city of Linwood. So yeah,
okay.
I'm Linwood, right next to Compton.
What's your demographic like?
Hispanics. We do have some from the Black community. We do have some there, but mostly Latinos. Latinas. Yeah, like more than half of them speak Spanish. So, and I don't know if it has to do with because I'm young, but I do sit and make the effort to talk to every single patient. And there's some guys. So it depends on the person. Some the women are great. They open up, they listen. I listen to them. It works well. Some men are hard-headed, you know, it's like, I don't want to hear this. Like, okay, well, And I just said, they're like, well, then tell me, what do you do? Like, tell me more about yourself. Forget diet. Just talk to me.
Yeah.
Build the rapport, because if how come the dialysis certified technician can do it, but I can't? Because they spend the time to sit there and listen to them, right?
Yeah.
That's the key.
Personal connection, identification with each other, right?
Yeah. It becomes a bond. It's a family. So just sitting there and just putting the time. Yeah, we're maybe really busy, having a chart, seeing the patients. It's a lot of work. We're assigned 120 patients for every one dietitian.
Yeah, the ratio is very, very.
So we're busy.
Very high.
Very high.
So on the side of okay, I'm your technician, right? And you're going to see John Smith. How would you feel if I said, "Hey, Jonathan, can I listen in on the conversation?" Is that something you encourage? Is that something that you actually, I would have to ask you, or would you be asking me, "Hey, come over here because I need you to back me up when I'm not here for the next 20 something days," right? Talking to this patient directly, you're here. I need you to back this one up. Make sure that they remember that they're supposed to bring that sodium level down from 5 to 4 at least to this month, right?
Yeah.
Or the daily intake this month.
Yeah.
Small incremental changes, like you had mentioned in a previous discussion.
Yeah. No, I definitely. Usually, I don't ask them, but when I do, they jump right in.
Yeah.
They jump in because, again, they're my backup. They're my muscles. They build the rapport. They build trust. Whatever they say, they'll listen to the technician.
Yep.
Right. To me, yeah, maybe I'll think about it, but I'll listen to Richard.
Yeah.
I listen to Michael. Listen to Yeah. So it's just, it comes down to, yes, using the whole, and that's the crazy part. For dialysis patient, you need a social worker, you need a dietitian, you need a technician, you need a nurse, you need a doctor. That's 5 different professions right there for one person.
Yep.
Yeah.
And that's just in the dialysis center. They probably have other specialists that they're working with, right? Like endocrinologist, cardiologist, podiatrist, gastroenterologist, right? They probably have a slew of specialists that they're working with besides their nephrologist.
Yeah.
So, so you definitely encourage the technician to be a part of the dietitian rounding. Do you prefer like an IDT round, like with the full group, or do you do your rounds just Jonathan and the patient?
Usually no. Sometimes the doctors come in. They used to let us know, but now they just kind of do their own thing.
Yeah.
But before COVID it was like, all right, Jonathan, I'm gonna be here on a Tuesday at Thursday at this time. That's a doctor telling me.
Yeah.
Have the paperwork ready, have the labs ready. I want the social worker there and the clinical coordinator. We're gonna do rounds.
So you guys knock it all out together.
Yeah.
And bring the technician in, or?
The doctor would not include, but I would ask the technician, because if I didn't know, like, hey, how is this patient doing with the fluid removal? Or ask the nurse.
Yeah, they know just like that, right? The text knows.
Instantly. Like, the patient said he only wants 1 kilo removed versus the 3 that the computer says. Doctor's like, what do you mean? Like, well, let's ask the patient.
Yeah.
So yeah, they're very vital.
So just to be sure on your position on this, if I'm your technician, I'm not imposing and I'm not being nosy. I'm doing what's right. I'm advocating for the patient by wanting to be a part of that conversation, understand what you're telling the patient that I work with Monday, Wednesday, Friday, so I can support what you've said.
I encourage them. I love it when they come look for me, because I'm in the office sometimes and it's boring work. And when they come look for me, I love it. It makes my day. When the technician comes and says, hey, this patient having issues with fluids, this patient has questions about food, you got it, I'm gonna be there. Years
ago, I worked with a dietitian, right? And I remember this clinic very well, very multi-ethnic. We had everything in there, every ethnicity, right? And there was a patient from Southeast Asia that wanted to eat bok choy. And was asking the dietitian about bok choy. And this dietitian said, well, I had never heard of that, so you better not eat it. And, and I just thought that was the stupidest response to a patient, right? I've never heard it, so better not eat it. Like, I would have, what's the right answer there? When like, you kind of talked about this, I think, before we got started today, but if you don't know the answer and it's not in the literature, what's the right answer for a patient? Is it don't eat it? Is it, how do you deal with that?
I said, let me get back to you. I said, usually I try to give that answer right away. There's so many computers now. I just like, okay, give me a minute. I'm going to go look for you. Yeah. I'm going to go look for you if that's good or not. Like, because I'm not aware of it. Like, like I said, there's some fruits that have been asked about in other countries that I don't know anything about. I'm like, well, let me look it up. Yeah. And I usually use the national USDA food database. The USDA food database is very, very informative, very, very detailed with the nutrients. And for bok choy, I knew that one has potassium. I know for sure. But that wasn't a good response. Just don't eat it. It's not a good response.
Well, the thing that I caught out of that was that this was a very, and even from my understanding with my wife, she's Filipina, that it's kind of like, this is the only thing that works for this thing, for this dish, right? And it's like a cultural thing. Like I love bok, so like I would like to have a better answer than you just, I don't know, so you better not eat it, right? And if that patient says that to the technician, like I actually had a patient call me from their dinner table one time, and I can't remember what it was, but like, hey, I'm about to eat, radish or whatever it was. Like, is it okay? And it was like late night, and no dietitian on hand, and I had to actually say like, I don't know, if it's questionable, moderation might be okay, but definitely don't overindulge tonight because I don't know the answer to that, and no dietitian on staff to ask that.
And if there's no information on it, because there are some that just none, I would tell them, okay, let's look at your labs, and like this looks like a root vegetable, right? It could be high in potassium, so include it 1 or 2 days, just specifically 1 or 2 days of the week.
Yeah,
have it those 2 days. We're gonna check your labs again. When is that time? We'll see if your potassium is high. We know it's that. If your phosphorus is high, it could be that.
Yeah.
So that's we kind of like you said, field test.
Yeah.
Now, there was something else I was going to mention. You were talking about with patients. That'll come back to me. But yeah.
But on those two that you just brought up, the potassium and the phosphorus, those are two elements that actually, in a previous conversation, you mentioned make sure you take your meds.
Yeah.
Right. So those are two elements that actually can be bound by medications. Right. Are you prescribing medications, binders, as far as phosphorus and potassium? Is your nephrologist doing that? What's your role in that regard?
Back in 2021, they removed that responsibility from us, which sucks, because we were able to prescribe those phosphorus binders for the phosphorus. It was easy, like, all right, we'll do this. We'll just call it in the pharmacy, done. Now it has to be a nurse practitioner or the doctor, or a physician assistant. So usually doctors trust us a lot. We're like, hey, can we try this? Yeah, sure. Whatever you want, Jonathan. So building rapport with the doctors too, if they trust you in your work. So it's our end to really build that rapport with the doctors and their trust. And then we get the recommendation, they do it. And then for potassium, there is two potassiums. There's three potassium medications. One is pretty standard. It shouldn't be used really, but it is because the insurance says we're going to cover this first one. It's the cheapest. And if that doesn't solve the issue, we'll try the other two expensive.
What's the first one, by the way?
Caxylate.
Yeah.
It's a caxylate or sodium.
K-exit.
K-exit, potassium. K-exit, also known as SPS, sodium polystyrene sulfonate, pretty long name. Then there's Veltassa and Lukelma. So, and for those two, one of them has a lot of sodium. So if they take it, they're going to be thirsty. So
let me ask you, phosphorus binders, but which one's more, phosphorus or potassium binders, which one's more common?
Phosphorus binders are more common, rarely used. Like for example, they have one patient, for some reason, the insurance doesn't want to cover the cheapest one, which is calcium acetate.
Yeah.
They only have 1 or 2 cases. Then then take Tums. Tums is something similar to calcium acetate. That's calcium carbonate.
Right.
So Tums in way can actually help lower phosphorus.
Right.
But if they're high risk of high calcium, then that's an adverse thing. They can't be having it. So it just depends on every person. Yeah. So phosphorus binders with the meals.
So I have an interesting story about phosphorus binders. 2005, 6, I had a patient sitting in a chair and he's like munching away on whatever he bought from the burger joint or something.
Yeah.
And I said, hey, Mr. So-and-so, like, it's your, big meal here. Like, are you supposed to be taking binders, or you prescribed binders? He said, oh yeah, I'm prescribed those, but I'm not taking that anymore. And I asked him why. And he said, I take them and I don't feel any different than if I don't take them. And that was really like, I was like, man, that makes a lot of sense.
Yeah.
If it doesn't do anything for me, why would I take this stuff? It costs me money even, right? To buy these things. And, I kind of went through an image gallery with him of calciphylaxis.
Oh, yeah.
And,
what a treat.
We went through these images and we got to, digits that had calciphylaxis and, we're losing turning into nubs and things like this. And then it got to a picture of a male private part. and it was necrotic.
Yeah.
And, it looked like you could just flick it and it would fall off, right? And he saw that and his eyes bugged up and he was like, whoa, hold on a second. Are you saying that this is what could happen if I don't take my phosphorus binders? And guess who started buying his phosphorus binders pretty quickly after that? So it's interesting when you talk about, not asking for help. And this was a Hispanic male. Sometimes consequences, need to be highlighted in chronic illness, especially preventable type of things like not taking your phosphorus binders, ending up with calciphylaxis and starting to have different sort of necrotic tissue, right? So thank you, Jonathan, for supporting the technician role in the nutrition and dietetics for the dialysis patient. And I guess, I'd like to kind of focus on one more thing before we end tonight is the oversight from Medicare in relation to the dietitian, scope of practice, qualification, and would love to kind of hear that part of it. Like, what is the qualification to actually oversee the care, the nutrition of a dialysis patient? And then what are the expected metrics? Like, what's consequential to you as a dietitian in a corporate environment? Like, what are the KPIs that you're looking for in the patient population?
Yeah. One thing for sure is calcium, corrected calcium. I have to keep that at 10.2 or lower. There's medications that help control it. Kaiser recently just released their grip on approving Cinecalc or Sensipar. I'm not sure about Parsabiv, but Sensipar, which is a medication that helps with calcium and parathyroid, hyperparathyroidism.
Yep.
They left that with DaVita, and they're like, you know what? We trust you, do it, because it was like jumping through like a hoop of fire. But now they're just like, all right, you do it. So there's been so much, like it just took off all the stress off our shoulders to try to get the approvals, get the doctor's signature, convince the Kaiser like the patient needs it for XYZ reasons. So there's that, and then the other one, the metrics would be fluids. Another main role responsibility, right, for the clinic is to remove fluids. Besides clean the uremic blood, all the toxins, remove fluids. The patient goes in the hospital for edema, pneumonia, in a way that kind of makes us look bad, because it's like, well, the hospital is going to say, you've been going to dialysis 3 days a week and you come in with fluids. What are they doing?
Yes.
It's an embarrassment. And I had to remind the patients and the technician, like, you know what, we got to do our job. Not saying you're not doing your job. Maybe the patient's having too much salt. So I have to get involved in like, okay, let's look at your diet. Are you eating too much salt?
Yeah.
They say, well, I don't drink too much, but if you're drinking salty, if you're eating salty food, it's going to make you naturally thirsty.
That's right.
And your body's not going to release that water when we do dialysis. So fluid is a big metric. So I look at the weight gain in between treatments and what's their weight after treatments. Are they leaving with too much weight than what they should be leaving with? So that's a big one, because we don't want patients going to the hospital for that.
So you mentioned calcium and fluid gains.
Yeah.
What you mentioned earlier, albumin. Is that still on the radar for you guys?
It is, but it's not. We're not. I guess held critical for it. So,
Gotcha.
but we have to look at it, because it is a form of nutritional assessment. Like if they're malnourished.
Yeah.
What am I doing to make sure they stay nourished, stay out of the hospital?
And from the full spectrum, that's like a value-based type of metric, right? Like if we don't do a good job on guiding the patient to good nutrition, then their nursing home's not going to do a good job on treating their infection or treating their wounds.
Yeah. Like it's a simple little information that that we think that the patient knows and they don't. Like for example, I think it was last week, we got a brand new patient. And I asked, okay, did anyone go over for your access? Because they came in with an access, which is very rare.
Yeah.
I said, has anyone gone over your care for your access in terms of when you sleep? Do you sleep on that arm or off your arm? They're like, well, I sleep on the arm. What do you mean? So no one told you? I'm like, no, you don't sleep on that arm, because it will create problems with your access. So simple things like that can be overseen. We just have to just keep it fundamentals with the patients. Like, okay, let's pretend that they don't know and go over it. If they say they know, back off, leave it like that, right?
Yeah.
So yeah.
So I want to highlight two things. You mentioned that there are certain things that are consequential and there's a quality incentive program, right? That's initiated from Medicare that says that basically if we don't meet certain metrics, like in this case, the calcium and the fluid weight gains, that we can actually lose or be penalized with some of our reimbursement.
Yeah.
So that's key, and that's fluid, right? It moves. Every year we change those metrics, right? Then we have conditions for coverage, right? Which the state or Medicare themselves will actually come into our facilities, physically be present, observe, query our staff. So two questions. In your experience, what's the interaction that you have with the state or Medicare when they come and survey? And then second, what is the peripheral knowledge that a dialysis technician needs in regard to the patient's diet or the support of their diet or their scope within all of this when the state comes in and says, hey, let's talk about the patient's nutrition. Like what's my response and what's my responsibility?
Yeah. Well, I have not been through a state survey. I got hired for the same clinic and I've been there since 2017. When I started it, that first month, the state was already there. The facility advisor and the dietitian told me, go hide in the office. You don't know anything. If you go on the floor and they see you mess up, even if you're new, they're gonna penalize. Yeah, it's gonna be deficiency. So just stay in the office because you're not properly trained. You're gonna give the wrong answer. No, just go hide in the office. So we're due for one. I know CMS has been backed up ever since COVID. Just put them back by a lot.
Well, I was just I'm a little surprised. That's a long time.
It is a long
in between a survey, and
yes.
It kind of, that's a whole nother conversation. But the accountability that our local and our federal government has towards quality on our patients, from what I'm just hearing from you, is it seems to be dashboarded because they do get metrics, right? But they're not looking and feeling. They're not actually validating, in this case, since 2017, that this clinic is actually up. And we haven't said the actual clinic name or anything like that. But this is not uncommon, right?
No, there's other clinics that are finally, and at least on our region, they're finally being surveyed after, and they haven't been surveyed longer than us. Yeah. So they're just finally catching up. I'm waiting.
So you know where they're at, right? They're at the skilled nursing facilities.
They stopped.
So, I mean, every single time it gets too hot or it gets too cold, the patient calls the state, right? And then the state has to respond.
Yeah.
There's a lot of abuse complaints in nursing homes. A lot of them actually valid complaints, right? Whether it be from family or staff or things like this. So there's a lot of attention in there, and we just don't have the resources, at least in California, to do this coverage. But again, if you had to speak through your opinion or subjectively here, as a dialysis technician, what should I be able to answer in regard to like my relationship with you as the dietitian of the patients that I take care of, or my scope in supporting all the nuggets that you provide these patients at least once a month?
Oh no, I just have them like mention the fluids to me. Are they coming in with too much or too little? Because I look at the fluids almost every day except Fridays, but I look at them daily. But the patients, there's 3 shifts. At least where I work at, there's 3 shifts. So there's some technicians that are very, very good with already just talking to the patients. Hey, you came in too much, extra treatment. At one point, our clinic was really bad with fluids, really bad. I mean, everyone was coming and no one was doing extra treatment. So we made a big push and incentive. The FA, the boss told me, hey, you're the fluid-wise advisor. You have to manage this now. How are you going to address the team about the importance of it? So it came down to educating the teammates the importance of it and the patients. And now it's just like clockwork. They're like, okay, this patient's over, come in extra. So and sometimes the patient says no, and that's fine. But I do come and they give me sometimes pushback, and I say that's fine. You know what? Just know that we're here for your best interest. I don't want you to come extra. I hate when patients come in extra. Like, I'd rather you do 3 days a week, but because you're fluid overloaded, we don't want you to go to the hospital. We're asking because we care, not because we want more money from you. This is because we care. We don't want you going to the hospital. So when they see that, okay, when it comes from that perspective that we're doing it because we care, that's our interest, that's our goal. Some will budge and say, okay, I will start doing extra treatment. And for the guys, oh man, those are the funny ones. Those are the ones that make me laugh because they're like, no, it's extra money.
Yeah.
So those require a more firm conversation and make them understand.
Yeah.
But once they get it, they get it. And so fluids and what's the other one? Oh, just dietary, just basic dietary questions. They ask them something, they're not sure, just let me know. And patients, some actually call me. Some actually, not on my personal cell phone, but I tell them, okay, if you're doing if you're Monday, Wednesday, Friday, they can call me Tuesdays or Thursdays, Sunday, Monday through Friday. And the same, vice versa. TTS, they can call me Monday, Wednesday, Friday. Don't wait till you get to the clinic. Call me. And I have some patients call me. And I tell them, call the clinic, ask for me. If you're about to eat, you're at the grocery store,
Yeah.
give me a call. And it has
Need
happened.
help shopping, huh?
Yeah.
Yeah.
Yeah, I said, like, they're paying me. I'm your resource. I want to make sure I can help you get to your goal of lowering your phosphorus and potassium, fluids. I'm open book.
So you don't go by just a playbook or a rubric. You're really there for as much as the patient needs from you within a professional constraint. You're willing to go that extra mile.
Yeah.
So Monday, Wednesday, Friday, Tuesday, Thursday, Saturday. So if I'm Monday, Wednesday, Friday, I have Saturday and Sunday off. If I'm Tuesday, Thursday, Saturday, I have Sunday and Monday off. And then you mentioned this extra treatments, right? And it's like, well, who wants extra treatment?
Right.
Well, Monday, Wednesday, Friday, I have just one day off. But from Friday to Monday, we refer to that as the killer gap or the killer weekend, right? This is when patients have their highest fluid gains, sodium gains, potassium gains, urea or toxic gain. Yeah, everything builds up, right? And we see hospitalizations, we see death rates at their highest after that weekend, right? So you mentioned like peritoneal, more frequent, continuous type of stuff, less hospitalizations, less sort of incidents like that. Yes, does have a risk of infection. Home hemodialysis more frequently and longer periods of time can also provide that same sort of benefit of like not having a weekend, right? You can do it more than 3 times a week, or you can do 4, 5, 6 times a week, or you can just avoid a weekend and kind of make it intermittent, changing your schedule up, right?
Right.
We haven't mentioned nocturnal dialysis, which is like, extended hours of dialysis.
Yes.
Nocturnal, insinuating while one sleeps, doesn't have to be while they sleep, right? But just more replacement value typically produces less complication on behalf of the patient, right? And, I just want to highlight that when you say extra treatments, that there is that weekend, that's typically where those things come into play, right? It's like, we can't make it through the weekend without ending up in the hospital. And hospitalization then brings on all sort of new risk, right?
Right. Oh, yeah. COVID, getting some type of, what is it? MRSA.
Right.
Happened.
Nosocomial infections, right? Yeah. There's you go into the hospital and you come out with something that you didn't enter in with quite often, especially for this patient, which is immune compromised, right?
Yeah.
So Jonathan, as kind of our MO here, if you had to give one piece of advice, I think we're really speaking to 2 groups today, to patients, or let's maybe 3, those who want to prevent the progression of their disease process, their chronic illness, like type 2 diabetes, hypertension, or obesity, those that are already there, or those that are caring from them, especially from the technician lens. What's your biggest and your most valuable piece of advice today for one or all of those audiences?
Yeah. There's a quote I love. I'm going to read this out. I mean,
Sure.
And I've posted this on social media, and the response is, "Oh, thanks for making me feel guilty." I'm like, it's not about guilt. That's not my intention.
Yeah.
It's just to make you guys aware, and your reactions making me aware that you're becoming aware of your decisions.
Right.
So it's by Joyce Day. And the quote is, "If you don't make time for your wellness, you will be forced to make time for your illness." So if you don't make time for your wellness, you will be forced to make time for your illness, right? So, that's pretty much sum it up. Start making small, good habits. The small, positive changes in your life will add up to, I would say very successful lab results, feeling better. For example, breakfast. Like if you're not eating breakfast, have breakfast. But what kind of breakfast? You know,
Right.
are we talking about like a bowl of cereal or like a McMuffin from McDonald's, right?
Right.
You're better off with a bowl of cereal with almond milk or just regular milk, depending on what kind of milk you like. Oatmeal, even better choice, right? Oatmeal or grits, something with fiber, some proteins like an egg or chicken. If you're vegetarian or vegan, you'll find your substitute. Just one small change, you know, that's it. That you will feel the change. The person will feel the change. Like, oh wow, I feel better. I feel energetic. I feel fresh. I feel clean. You know, that would be my message. Is just make one small change for yourself, for nobody else. Do it for yourself. Yeah.
I think the last time we talked, I and I don't know where it came from, but like choose your hard, right? Now or later. And what you just said is like, you know, take care of yourself now, which is hard.
It's hard.
Like to actually put good stuff in your body, to get some rest, to exercise, to be mentally, you know, attuned. All of those things are difficult, right? Especially in the US and especially in a fast-paced area like California. But it's also very hard to take care of chronic illness. And you know, it comes down to an issue of like discipline now or like necessity later, right?
Yeah.
Discipline now in doing all those things that are just hard to do, or necessity. And if you don't do it, your life is on the line, right?
Yeah.
I can tell you that I'm in that boat right now, you know, like of like just watching my age, watching sugar, watching weight, all these sort of things. And even since our last conversation, it's been really on my mind. So if I were to speak to, you know, all three of those groups again, you know, it would be thinking about your hard now or hard later. So those who want to prevent, you know, make some sacrifice. For those that are in the position where they've already maybe missed some of the signs and they're in a chronic condition like diabetes, hypertension, or chronic kidney disease, it's not the end of it, right?
Correct.
There's still, you can halt a lot of this from getting worse. You can manage symptoms. You can enjoy life, right? And I think it's, hopefully you get a better lens on enjoying life when chronic illness creeps up on you.
Yeah. For those who have diabetes, I have definitely seen patients where once you're diagnosed diabetic, that's for life. Your pancreas is the size of this is the size of your pancreas. Once you're diabetic, that means that it's difficult for your body to control insulin, the sugar. I've heard plenty of times that they say I'm no longer diabetic. I don't take that away from them. I said, good. Whatever you're doing, keep on doing it.
Right.
Because I know for a fact it's not true. They have it. But if they strongly believe that they got rid of it, it's not there, and their sugars are good, which are good, keep at it.
Right.
You know?
Yeah.
Ignorance is bliss. You know? And in this way, it's helping them a lot. You know? They're like, believe it. It makes me feel good. Go for it.
Yep.
I am not going to correct that. Just you do what you do. You know? Yeah.
Jonathan, I really enjoyed this conversation. I want to just make sure that, again, we keep this dialogue going. I think the partnership between dietitians, patients, and technicians is super important. Over the years that I've been doing this, I've looked at two categories of discipline in the renal team that are somewhat overlooked. And I think one of them is the dietitian, one of them is the social worker. And specifically from the dietitian, I see you as an educator. You know, that's like the number one job is like, you've got to get through my thick skull so that I go home and do the right things, right? And I appreciate the relationship between the dialysis technician and the patient and the dietitian in a way that I think the segue to success, the planting of suggestions and the subconscious, really, we have much more value when we include the dialysis technician. So I appreciate that you also see that value and hope that this conversation today would encourage dialysis techs to find their role in relation to the nutritional status of dialysis patients in their own life.
There's a superstar technician who she's very good at voicing her her opinion, and she's just very good at being vocal. There was a patient that came in on Monday, wasn't supposed to come in until Tuesday. You only got 2 hours instead of 3 hours and 15 minutes on Monday. She was concerned. She's like, he missed his Tuesday treatment. He's coming Wednesday, which is today. But he's only going to do 2 hours Wednesday as extra treatment. So he's only getting 2 and 2 hours. He's not getting his full treatment.
Yeah.
I love that. Like, you genuinely care about his health, because in the end, it's not about billing. Because in the end, the second the blood hits the line, the insurance is billed. It doesn't matter if it's an hour.
Right. Yeah.
She cared about the patient, and that made my heart melt. I'm like, you really care.
Yep.
You know? So, and everyone, the nurse didn't see it. Well, I didn't see it because there's so many patients. The same with social worker, but she took the effort to pull me aside and like let me know. She's like, he didn't come to Tuesday. Tomorrow, which is today, he's only coming for 2 hours.
Yeah.
Can you do something about it? Yep. Called the nursing home. Came 3 hours and 15 minutes today. So, you know, one less person at the hospital. You know, we cleaned his blood. So
can't have enough on your team, right? Enough people on your team, and it's a great role to fulfill. I think being a part of these patients' teams. Appreciate you, Jonathan, and look forward to further conversations and seeing you on the circuits of the conferences, huh?
Yeah, always.
Thanks, man. Appreciate you.
This episode has been brought to you by Dialysis Education Services.